Dr. Jamil and Professor Sonak. Okay, so we're honored to have with us Professor Sonak. He's a professor, and a clinical pharmacist with lots of years of experience, working in Kenya and other places, working with those with chronic diseases to improve health outcomes, supply chain management, and a whole wide range of expertise. And he'll be our first speaker for today, and we'll hand over to Dr. Jamil, who will be talking to us as well on the same topic, cutting through the noise and getting the latest evidence behind medications for COVID-19. So, there are lots so we know what we're using in Nigeria, but some of us don't know, like, what is the why? Why is it why are we using it? Is it a cure? Is it a palliative? What exactly is the role of these medications in the treatment of COVID-19? And also, we all know we've been told to boost our immunity, but what is the role of the vitamins or nutrition in preventing or safeguarding against COVID-19? Jamil is a member of faculty at the Meier University School of Medicine in Kenya. He's a physician who is a technical advisor, in the COVID response for the whole of Western Kenya, and so brings a lot of experience and expertise to this discussion. And so right now, Sonak, we're going to hand over to you for you to share your screen and take it away.
Great. Let me just pull up my slides. Great. So thank you for the introduction. If you have a problem hearing me, or if something goes wrong, please just interrupt me so I don't talk to a blank screen, and make sure that everybody can hear. But as great. So as Kendra mentioned, both myself and Jamil will be giving this presentation, and the hope is that we can share our perspectives. The thing that's unique about our particular expertise is that we've worked together in Western Kenya for the past couple of years, and I've been based in Kenya full-time for the past 12 years. And I give you this context because I know when I get lectures from people from the West who haven't practiced in Africa, there is a little bit of nuance that is missed. And I want to say that most of my experience is in practicing in Africa. So my hope is that we give you a contextualized message that reflects some of the realities that you guys might have versus some of the realities that might be in the US or other countries around the world. And at the same time, I have not practiced in Nigeria, so my hope is to also learn a little bit. I see that the questions have come up, so I think I can pause now and let you guys answer the questions.
Yes, please. Thank you.
Great.
So over to you, everyone. We have 10 questions in all. So just tap at what you think is the answer if you're answering with your phone, and if with your laptop, go scroll the mouse over what you think is the answer and tap. With 30 seconds in, I'm going to give us about 3 minutes. I'm assuming everybody can see the poll. If you can't see the poll, just chat in and let us know. So 12% of people have completed. Looking for a higher completion rate. Is okay not to know the answer now. The most important thing is knowing the answer at the end. Okay, we're up to 30%. Okay, we're close to 50%. If you're joining us just quickly, 1 minute more. Okay. We're climbing, almost 70% done. I would give 30 seconds more. I'm a very lenient examiner. I wonder whether Professor Sonak is.
You'll have to ask my students.
Dr.
think
Jamil, what about you? Dr. Jamil, will you consider yourself a lenient examiner?
I don't know. Being a student myself, I probably would be inclined to be lenient.
I would say that age has made me more lenient. When I first started, I was not very lenient.
Ah, so the higher you've gone, you've been nicer with the year.
I'm more understanding. And having a family and kids also makes one more understanding of the situations of others. Before you have a family and kid, you basically don't understand that other people might have things that take up their time. But once you have a family, you start to realize that there's other things outside of work.
I'd like to hear what the participants think. So if you are in a teaching position, do you agree? Are you more lenient with age, or have you become tougher? It would be, because I know we have lots of doctors also double as teachers to medical students and residents. So it would be good to know that. Okay. So we have about 76 people in, and we are going to close the polls in 5, 4, 3, 2, 1. 80% completed. I'm ending the polls. Okay, so I'm going to share. the results, and we see that for number one, who should use hydroxychloroquine based on currently available evidence. The highest score is for 28%. This was really well distributed. 28% said all of the above. Number two, which of the following medications has shown initial positive findings in directly treating coronavirus? And we have 73% being the highest for Remdesivir. Number three is based on currently available evidence, all patients with coronavirus should receive repeated infusions of vitamins, and we're right in the middle of this. 50% said true, 50% said false. Interesting. Thrombosis is a potential consequence of coronavirus infection. 83% said true. What is the main life-threatening side effect of hydroxychloroquine? And 78% said ventricular arrhythmias. What should we promote in terms of mineral and vitamin supplementation? 55% said people with documented deficiencies of vitamins, such as vitamin D, should make sure they take their supplements. That's the highest answer. 7 says, which of the following are risk factors expected to increase the risk for complication from coronavirus? 78% of people said all of the above. And then Remdesivir, sorry if I'm not pronouncing that right, has demonstrated complete resolution in all hospitalized patients who have taken the drug early in their treatment. This is pretty close. 48% and 52%. Sorry, it rounds it up sometimes. So 48% said true, 52-point-something% said false. The decision to reopen in many countries has been based primarily on the public health predictions that the coronavirus will no longer spread in the regions which have reopened. 85% of people say false. Vaccines have now been approved and are currently available and ready for use by the general public. 95% of people say false. Okay, so over to you.
Great. Thank you for that. So I think you've heard a brief introduction on us. The other thing I would mention is that most of our work, both Jamil and I, focuses on chronic diseases. And I would add that Jamil is an expert on diabetes and unlocking and identifying some of the underpinnings of the biochemistry of diabetes in African populations, especially those in Kenya. And so he brings a much more lab-based perspective and investigational perspective to this, which is why I thought it would be good to add him to the panel and for us to jointly do this presentation so you can hear both perspectives. And the other thing I would add is that I recently, because of my university's restrictions, I couldn't be in Kenya right now, and I'm back in the US. And so I also have the perspective of what it's like in the US. And my hope was to kind of merge some of the things that we're seeing in the US as we respond to coronavirus with some of the things that we're seeing in Kenya and blend those two together. The other thing that I want to emphasize again is that neither Jamil or I have considerable experience practicing in Nigeria, but I thought at a minimum I would share the guidance that the Nigerian CDC gives for treating coronavirus. And my hope is to go with this and then provide data on some of the agents that they mention in the guidelines. And since we have a wide variety of different providers, which I think is absolutely fantastic, because it's clear from all the studies, everything we know, that an interdisciplinary team is required to have an effect on many of these health challenges we face. I thought I would share the PPE guidance and the protective equipment guidance, because in terms of preventing coronavirus for healthcare workers, these are probably the most effective strategies that you can use. So I just wanted to have that in as a reminder, as you can see on the slide. But this is your Nigerian CDC guidelines. There's also links to all of the references that I use in this. So I'm hoping that you can click on them as you see fit after the presentation. And I've shared the slides, and I hope other people can receive them and look at them as well. The one other big caveat I want to mention is that if you talk to many of these journals and many of the people publishing this work, they would all very convincingly tell you that they have never received as many submissions and as much data as they've received at any point in their history as journal editors. And so the other thing I want to mention, and the reason why these links are important, is that the information and the data we have on coronavirus is literally changing every minute. And so I want you to be able to know that what I tell you today might change in a couple of days. And I can tell you that I've done presentations in the past where new studies have come out, and then 2 days later, basically, a lot of the things that I said were changed. And so I want to make sure that people stay up to date, because this is a rapidly changing field, and the information on this is rapidly evolving. So I just want to make sure everybody has that context, and just wanted to quickly go over some of the guidance from the Nigerian CDC on what treatments they're recommending, because that essentially is what I'm assuming most of the providers will follow. So if you can look over here, I'm hoping you can see my mouse. The basic things here is that we're doing supportive management with oxygen, ventilation support when possible, and then you can also see the fluid dynamics here, mostly just supportive care, but avoid aggressive fluid resuscitation. And then onto the treatment, this is where we're going to focus most of our energy. You can see some of the things here. They are recommending Remdesivir and also mentioning other antiviral agents like Lopinavir-Ritonavir. And I'm guessing many of you have provided care during the HIV era and know Lopinavir-Ritonavir well, which is an HIV medication. So we'll cover the data on Lopinavir-Ritonavir for coronavirus, and then you can see some of these other empiric therapy recommendations. So I wanted to go in a little bit more detail into the questions that I'm hoping to answer through the presentation. So we're going to look at what the current treatment options are, the current preventative options, and I'll even answer that one simply now, is that outside of social distancing and PPE, there isn't really any great data on things that can effectively prevent coronavirus. So the things that we do know that work are social distancing and effective PPE wearing whenever you're in contact with people who have potentially been exposed or have coronavirus. And then I'll also talk a little bit about vitamin and mineral supplementation. And then lastly, we'll talk about what doesn't work. I wanted to once again give a little bit more context on the perspective we come from for both Jamil and I. We work with a program called AMPATH, which is the academic model providing access to healthcare. So we're a Nobel Prize nominated program that has brought together all of these partners that you see here on the right side of the screen. So all of these universities are part of this broad consortium that work together with the Ministry of Health in Kenya, the Moi University School of Medicine, which is one of the main medical schools in Kenya, and then Moi Teaching and Referral Hospital, which is the main referral hospital. So we all work together. We are not an NGO. We are partners with all of these partners, and all of our activities are focused on addressing the needs of Western Kenya. This includes care, teaching, and research, and we do that across the vast catchment area that you can see in the map of Kenya on the left. So this is basically all the areas we serve. It's a catchment population of over 8 million people, and we have over 165,000 patients who have HIV who are actively in our care program. So we're one of the large programs, and now we're transitioning that HIV care model into a population health model that basically addresses everything from pregnancy to providing radiotherapy for cancer. So as I said before, one of the things that I want to give you tools to do is to follow the data on your own. So this tool right here, this is a screenshot from about 2 days ago. This is something that anybody can freely use. It's done by Johns Hopkins, which is one of our consortium partners. But basically, anybody with this link address can basically find out where coronavirus is across the world. And as you can see here, this gives you the number of confirmed cases for Nigeria and the number of deaths. So, despite the high population of Nigeria is doing fairly well, even when you look at it per capita, compared to a country like the US. So in the US, I guess this is part of Trump's mandate to make America first. We are now have the most cases of coronavirus in the world, and have a death rate that has now crossed 100,000 people. And so despite all of these messages of making America first, we're also becoming first in things that we probably would not want to be first in. And so as you look at Africa, I think there's an article in The Guardian that I'm happy to share that talks about how little we are celebrating some of the wins that are happening in Africa in terms of preventing the spread of this, because there's a lot of concern, including from people like me, that coronavirus will spread like wildfire in Africa, largely because, not to overly generalize, but there's a much less individualistic sense in Africa. And there's much more community-centered activities, whereas in America, it's much more individualistic. And those kinds of dynamics are things that can really spread something like coronavirus. But what we're seeing is a lot of the preventative measures that have been taken in Africa have really limited the spread of the virus and have not led to this rapid surge of numbers that's as bad as it has been in other places like in Europe and in the US. So, I think there is a need to actually celebrate some of the successes we've had in Africa because the spread has not been quite as bad as a lot of people are predicted. Now, I say this with the acknowledgement that we are far from being out of the woods. And if we start to lessen some of these restrictions and ease up on some of these things, please know that it will spread and you'll see a much higher number than what you currently have. But as you can see in this slide, Nigeria has roughly around 8,000 confirmed cases and about 233 deaths from coronavirus. And if you want to check out this map on your own, you can see the web address there. It can answer all types of epidemiological questions for you and give you numbers on the burden of coronavirus across the world. So very quickly, just wanted to cover the epidemiology again, because this affects treatment. I don't want to spend much time on this because my goal is not to talk about the epi of this, but I do want to talk briefly about what we're seeing. What we're seeing in terms of who is most likely to suffer from complications of coronavirus. So the biggest one that I think is worth mentioning is age. This one definitely confers additional risk. If you look at this chart from the WHO, this is an earlier one. This shows you the percent risk of death if you're infected with coronavirus based on age. So if you look here, this is the percent risk by age on the y-axis. On the x-axis, this is the age groupings. So if you're 80 and over, you have a 14.8% risk of death, which is why there's a lot of ongoing efforts to ensure that the elderly population is not infected and is avoids transmission of coronavirus. You can see over here, this is the percent risk by pre-existing conditions. You can see all of the pre-existing conditions that basically confer risk for coronavirus. So cardiovascular disease, diabetes, chronic respiratory illness, hypertension, and cancer all increase the risk. And these are things that we need to keep an eye on because I'm sure many of you see patients with these diseases. And it's important to make sure that we minimize the risk of transmission to them because they have a higher risk of death. I just wanted to share some data from America, largely because this has been getting a lot of headlines, and I wanted to give you a little bit more context for it. So one of the other things that we're seeing in America, which is essentially a melting pot of different cultures and races, African American populations are facing a disproportionate burden of the risk. And there's been a lot of investigation into why this is. And I'm not going to say that there's a definitive answer, but the things that we do know is that we're not entirely sure that it's actually genetically based. So I don't want to say that African Americans in general have an increased risk because we don't know that. What we do know is that a lot of times they're on the front lines and are working a lot of these jobs that increase their exposure. There's also a lot of issues with access to healthcare that are leading to additional mortality and additional complications for them. So what we're seeing and what we're thinking is that it's not necessarily related just to the race. It's related to all these other factors related to social determinants of health. So whether they have access to care, whether they have access to good food, whether they're required to, whether they're able to adhere to social distancing. We're finding that Africans in America have less freedom to do some of those things. And therefore, that's what we think is contributing to the risk. But we don't know definitively if this is genetically based. The other thing we know is that African Americans tend to have a higher prevalence of some of these other risk factors that I just mentioned, like diabetes and cardiovascular disease. So we also think that is contributing to the risk as well. But we're not sure yet. I just thought I would share the numbers because this is something that's been getting a lot of headlines in the US and probably around the world to some extent. So just to give you a sense of some of the things that we'll discover, that we'll talk about through this lecture, here's a listing of some of the treatment options. I'll talk about the main two for the existing medications, mainly hydroxychloroquine and Lopinavir-Ritonavir. And then for the medications in clinical trials, we'll talk about Remdesivir. And then lastly, we'll very briefly talk about vaccine data. So this is an interesting diagram that shows the mechanism of action for how we're targeting coronavirus. And I don't want to go into the details of all of this, but I do want to share it. And you can see the link to this figure so that you can read this article on your own if you're more interested in the mechanism of action of these different drugs. But you can see that the drugs that we're looking at all work in different places for coronavirus, as opposed to all working in the same place. And very similar to what we saw with HIV in the early days, we tried to attack the HIV virus from different points. So if you look at Lopinavir-Ritonavir, this is working just like it does for HIV in terms of working on the copying of the virus into more copies. And so Lopinavir-Ritonavir is working there. You can see other strategies that are working on adhesion and entry of the viral particles into the cell. But this is just a very brief summary of what we're seeing with some of the treatment options for this. The other thing I wanted to do, and I hate being somebody who reads slides to you and puts slides with a lot of text. The only reason I've done that here is because I want you to read the recommendations for yourself, because they will all change very rapidly. I will summarize them for you, but I just wanted to share them exactly as they're written, because there is a lot of nuance to the way that they're written. So the National Institutes of Health is an institution in the US that's probably one of the largest research funding institutions in the world, and they've been basically collating all the data on treatments for coronavirus and then giving out guidances based on their expert panel. And so I just wanted to share some of these guidances with you, because this is probably one of the most up-to-date set of guidelines that you have for coronavirus that is based on the data. I will not read all these to you because I will explain them as we go throughout the slides, but you do have this for your reference in case you want to look at it. And once again, if you want to check this on your own, because I'm sure it will change within the next couple of days or the next couple of weeks, there is a link to this resource at the bottom here that you can click on and you can find this information, because what we say today will very likely change in the forthcoming days. And we'll go over some of these recommendations throughout the presentation. This is, once again, just for your reference. I do not expect anybody to read this or know this. This is from that slide that I mentioned from JAMA with the figure of the mechanism of action. This is just a very brief summary of the treatments that are being tested. We don't have the time to cover all of those, but I did think it would be good to include it for your reference here. We'll talk about some of the details of the treatments that are worth discussing. And this is the continuation of that. Once again, here for your reference, but we will not be discussing this whole chart in detail. All right, so I wanted to start diving into some of the data and some of the information that we have. So this is, I wanted to first start talking about hydroxychloroquine. And the reason that I decided to talk about this one first is because there's a lot of news headlines about hydroxychloroquine as we speak. So you can see here's one to the left. The WHO halted a hydroxychloroquine trial over safety concerns, and we'll talk about the study that is based on. In the middle, you can see that Nigeria goes on with hydroxychloroquine clinical trials. And I just want to give some background on why that is. And this was an article that talks about some of the health officials in Nigeria and their justification for doing this. One of the things that they said was that we're not sure if hydroxychloroquine will have the same effect on Nigerian populations as it had in some of these broader studies. So they wanted to continue with the clinical trial that they're doing in Nigeria because they want to see if it has the same effect on Nigerian populations as it does on other populations. And there is a good bit of legitimacy to that. My goal, though, is to share the data that we have right now and talk a little bit more about what we know so that you can make an informed decision for your patients about whether this makes sense or not. And especially as I'm sure many of your family members, many members in the community will ask you questions, I think it's very important to be equipped with the data and the basic scientific evidence that's backing this. And just to give you the perspective from America, I found this screen that included a picture of, very interesting, because you can see the headline is hydroxychloroquine provides no COVID-19 help, increases risk as the study finds. And then in the caption below, you see President Trump says he is taking hydroxychloroquine. And so this is part of the challenge between listening to public officials who might not understand or take the science seriously and relying on them for a lot of your guidance. And I say this from the perspective of a lot of the guidance in the US is the scientists are saying one thing and then our president is saying something very different. And when you question the public, a lot of times they say, well, you know, the president isn't wearing a mask, so I'm not going to wear a mask. The president's taking hydroxychloroquine, so I want to take it. I want people to have the data so they can make informed decisions on their own, and that's part of my goal of what we're sharing here today. So as I said before, I wanted to share the NIH guidance on these different treatments. Once again, the NIH is a government-funded agency. So when I'm telling you my opinion, I will openly admit that. So in my opinion, the recommendations that NIH is making on hydroxychloroquine are not as strong as I would hope they would be. After reviewing the data on my own, I don't think, I would basically recommend against it at this point. If there are new studies that come out and say, you know, hydroxychloroquine is effective and, you know, a large-scale trial proves it, then I would change my opinion. But based on what we have right now, my own personal opinion would be to not use hydroxychloroquine at scale. And so this first recommendation that the NIH has that says there's insufficient clinical data to recommend either for or against it, I don't think that's strong enough. Based on what we know right now, I would say that there is not enough evidence to justify its use. And then, you know, they also recommend against using hydroxychloroquine. I also just want to emphasize, you can see right here, there is a risk for dysrhythmias with hydroxychloroquine. And one of my colleagues is one of the world leading experts on this. And based on his findings in the early days of studying this, even with healthy populations, I would really have pause with giving out this medication because of the potential risks of it. So it is not a completely benign drug. There are risks with ventricular arrhythmias with using this medication. I also think it's useful to go over the story of this. So, and once again, I'll use an American example because I think a lot of the things that the president has said have influenced populations all over the world. And I'm sure many of you have seen the headlines that after Trump promoted that hydroxychloroquine would work and what have you got to lose, there was at least 2 or 3 people who overdosed on hydroxychloroquine in Nigeria. So his words actually have consequences, not just in the US, but based all over the world. So I wanted to very briefly go over some of the studies that his proclamation was based on and share the story of why people thought hydroxychloroquine was great. So this was a study that was published recently that looks at, this is the original study that gave people a lot of confidence that it would work. So this was an open label, non-randomized study of 26 patients. So for the people who do research or who have seen studies, most people would agree that you would not base a clinical recommendation on a study of 26 people, let alone a study that was non-randomized and a study that was open label, because there is a lot of bias that can be introduced. For example, if it's an open label study and you think that hydroxychloroquine works, then you're probably going to follow those patients more carefully and do more supportive care to make sure it works. And so that's what it seems like happened in this study to some extent, because there was a lot of differences between the populations. The populations weren't equal that received the hydroxychloroquine versus getting no treatment. And so a lot of people who've looked at this study have said, well, you haven't fully disclosed all the characteristics of these populations, and we're not sure if they're actually even the same and that they can be compared. So despite the fact that within this study, they found very statistic differences in virological suppression of coronavirus, there's a lot of issues with the methodology of the study, and there's been retractions from the journal that published this. There's been a lot of issues with the way they did this study. So I want to make sure that everybody is aware that this proclamation of suggesting that hydroxychloroquine works from President Trump and other officials is largely based off this one fairly poorly conducted study, which was open label, which means the doctors and the patients all knew what the drugs were and who was getting it, and it was non-randomized, meaning that people who are entered into this trial got the drug, it wasn't random. It was the providers basically got to choose who got it, as opposed to having it done in a random fashion. So this is not strong data, despite the fact that it's statistically significant. And in my reading of this study, I would not use this to justify using hydroxychloroquine. And so here's just more graphs showing it. You know, it looks very impressive in a graph, but once again, this is a small sample of only 26 patients. That is not suggestive, that is not reliable enough to make definitive statements of. And I'll show you the larger scale studies. Once again, here's another slide which shows, you know, the black line is showing, on the y-axis, you see the percentage of patients with positive samples, meaning that they still have coronavirus after a couple of days. And then you can see the days afterwards on the x-axis. The control is the black line. Hydroxychloroquine is the blue line, and then hydroxychloroquine plus Azithro is the green line. Once again, it looks very, very favorable, but this is a very small sample of patients. And once again, the data cannot be trusted because of the way they did the study. But I wanted to give you the data on why people were very excited about hydroxychloroquine, but most scientists and most providers who read the study were not excited about it. Whereas most public health officials were not saying that the data was sufficient to actually make this recommendation to use it. So I wanted to give you the study that led to a lot of these, the recent proclamations saying that hydroxychloroquine actually increases the risk. And so this was a registry study that looked at roughly, all in all, they had, you know, over 98,000 patients that were included in this registry. And then in the study itself, they looked at 96,000 patients. And the way they basically did this study was they looked at hospital registries from all over the world. So there was roughly around 671 hospitals that they looked at. And before anybody asked the question, about 30 of those hospitals were in Africa. So most of the hospitals weren't coming from Africa, but they did include some hospitals from Africa and had populations from Africa. So they included this large sample of people who are getting routine clinical care in hospitals across the world. And so in total, they had about 96,000 patients included. And you can see they had 81,000 in the control group who did not get hydroxychloroquine or chloroquine, and then 15,000 roughly in the treatment groups. And so this is a large study looking at a large data set to assess what chloroquine impact actually looks like. And I'll once again mention that I don't have the time to go over the in-depth details of the study, but I just wanted to share some of the key findings of it, because this is the study that really all of the recent restrictions, the recent changes to hydroxychloroquine are based off of. So in this slide, this is basically a forest plot that shows you the risk of death for patients with coronavirus based on these other factors. So you can see that the age per year, this increases the risk slightly, BMI, female, you can see all of these things. I want to focus on some of these other ones. You can see that if they were Black, they had an increased risk of death. And we don't know exactly why that is. It goes back to the point I was making before. Arrhythmias, you can see all of these things, diabetes, hypertension, hyperlipidemia, COPD, all those risk factors that I mentioned. Even current smokers had an increased risk of death in this large registry analysis. And so what this really does for you is it puts a lot of these risks into context. So now if you look down here, you see the risk of death when you take hydroxychloroquine or chloroquine or hydroxychloroquine with the macrolide. And basically what you see is that there's an increased risk of death. And when you compare it to some of these, you can see that the risk of death is similar to being Black or being having any of these other issues, whether it's diabetes or congestive heart failure. So this is why a lot of these big headlines have come out and said, taking hydroxychloroquine and taking some of these medications actually increases your risk of death. Now, to give a full analysis of this study, the thing that's worth mentioning is that this is a registry study, which is looking at all the data that's available and not necessarily factoring in some of the bias that might be there. Most people who are clinicians would probably realize that patients who are more severely ill, you're going to try to give treatment to. And so that's what may have contributed to hydroxychloroquine and chloroquine showing increased risk of death in this study. But basically you can see here that taking any of these medications, any of these combinations, basically increases your risk of death when looking at a general population. So this is why a lot of the enthusiasm over hydroxychloroquine has gone down. So I just want to show another slide again, showing that the risk of ventricular arrhythmia, which is the main side effect of hydroxychloroquine, is also pretty significant. So if you look down here, this is showing you that if your risk drops, then you have a decreased risk of ventricular arrhythmia. And then if you're on this side, that basically means you have an increased risk of ventricular arrhythmia. Basically, you can see here that hydroxychloroquine and chloroquine both increase your risk of ventricular arrhythmias. So if this drug was not toxic and didn't have any major side effects, then I'd much be more comfortable with saying, just go ahead and try it. It's probably not going to hurt you. But we see here from this study that there is an increased risk of certain side effects that are potentially life-threatening, like ventricular arrhythmia. So it is not a completely benign drug. It actually does have fairly toxic effects on your heart in a small portion of the population. So this is a very small portion of the population get these risks, but you can see that there is an additional risk for ventricular arrhythmia compared to a lot of these other factors where we did not see this risk. So that's one of the main side effects to worry about with hydroxychloroquine. If you wanted to use it, my main recommendation would be to make sure that you could monitor for ventricular arrhythmias and do an EKG for patients who might need it. So now I wanted to shift over to Lopinavir-Ritonavir and coronavirus, because once again, as I showed you in the NCDC guidelines, this is one of the treatments that's recommended by the Nigerian government, and there is some conflicting data to say that it might be good or it might not be good. So I can't give you a definitive recommendation. My only goal is to share the data with you on what this actually looks like. So basically, you can see here that Lopinavir-Ritonavir, the NIH, which is the US panel, recommends against it based on the data that's currently available. And a lot of this is because there's only small trials that have been done so far. There might be emerging data that comes out in the future, but so far we only have limited evidence of this. And I'll quickly go through the trial evidence for this. This is a recently published study in New England Journal from just a couple of days ago. What we found here was that this y-axis is looking at the viral load of coronavirus, and this is looking at the days of treatment. Basically, what you can see here is that Lopinavir-Ritonavir trended towards being better, but we did not find statistical significance. And the same here, we found that it trended towards benefit, but not statistically significant. The thing to note here, though, is that this was done in a patient population with severe coronavirus. And it was a fairly small sample of less than 200 patients that were on it. There was 199 patients total. So it wasn't powered to detect smaller differences. And so it's because of that that we're not sure if Lopinavir-Ritonavir can be effective. It did trend towards a benefit, but was not statistically significant benefit. So we're kind of muted on whether we think it's worthwhile or not. Here's another study that shows where there's conflict. So the Lancet also published a study about 3 days ago showing the use of Lopinavir-Ritonavir with ribavirin and interferon-1 beta in mild to moderate coronavirus infection. And I don't want to go into the details of this, but basically this was a fairly small study, less than 150 patients. But basically they showed that this combination of all these drugs was able to get a statistically significant improvement in some of these markers that they looked at for coronavirus. So our sense at this point is that it could be mildly effective in mild to moderate, but still too small of a study to make definitive recommendations from. And just one more thing I'll say on that before I hand it over to Jamil. For those of you who've worked with HIV populations, you know that Lopinavir-Ritonavir is not a benign drug. It has many drug interactions. It has many gastrointestinal side effects, very intense diarrhea and vomiting and upset stomach. And it can cause liver problems as well. So it's not a benign drug. But now that I've talked about all the drugs that are more conflicting, I thought I would hand it over to Jamil to talk briefly about Remdesivir.
Thank you, Sonak. Thank you, Sonak, for the very enlightening discussion, and thank you, Kendra, for the very kind introduction. And really, thank you for having me here today to talk about Remdesivir. I'm quite humbled and really excited. So without further ado, I'll probably start off by discussing Remdesivir in the context of the other antiviral agents. And probably I would suggest we have a lookout for other antiviral agents that might be repurposed, or some which are all still in the investigational phase towards the treatment of COVID-19. And briefly, maybe I would just touch on tenofovir, because I think most of us are quite familiar with the drug, and we use it mainly for treatment of HIV and hepatitis B patients. Based on chemoinformatic in silico analysis, it's been shown that tenofovir might have the ability to bind on SARS coronavirus 2 targets, specifically the RNA-dependent RNA polymerase. So there's been a call and a little bit of chatter that it might be worthwhile conducting human clinical trials to see how tenofovir works against coronavirus disease. Galidesivir is a broad-acting, direct-acting antiviral agent, and it's been found to have an effect against a multitude of RNA viruses, and there are currently ongoing phase 1 trials to see whether it might be effective in Ebola virus, and it might be also tested against SARS coronavirus 2. Now, sofosbuvir, together with its other drug, the names are quite a mouthful, velpatasvir. These are drugs that have been used for treatment of hepatitis C virus, and to the best of my knowledge is that there's a clinical trial going on in Iran right now trying to see whether it might have an effect against SARS coronavirus 2 and COVID-19 disease. I won't talk much about ribavirin, which is also another direct-acting antiviral agent, and I'll go back to now remdesivir. So remdesivir is a direct-acting antiviral agent, and the target, it's a nucleoside analog and acts as a prodrug. Once it's internalized, it becomes a nucleotide analog and works by competitively inhibiting the actions of the RNA-dependent RNA polymerase. So remdesivir was first developed during the peak of the Ebola crisis in West Africa in 2016, sorry. And the reason why it was developed is that it was thought it might have an effect against Ebola virus. But unfortunately, that didn't turn out to be true. But then the drug did show from in vitro analysis studies efficacy against a wide range of RNA viruses, including coronaviruses. At that time, it was tested against SARS coronavirus, and it was found to be efficacious. And it was also tested against the MERS coronavirus and found to be efficacious. And in vivo animal studies, it was also found to be efficacious in treating MERS among animal models of non-human primate animal models. So for this reason, it was a very promising candidate, and it was tested against SARS coronavirus 2 during the wake of COVID-19 pandemic. Next slide, please. Next slide. Oh, yeah, thank you. So, and the first human data to come out came from the US, where there was a case of a 35-year-old gentleman in Washington who was diagnosed with COVID-19, and this was actually the first case of COVID-19 in the US. And 4 days into the infection, he walked himself into the emergency department and then later was hospitalized. And his condition was deteriorating. He was even started empiric antibiotic therapy for what was thought to be hospital-acquired pneumonia, but he wasn't improving. And then he required oxygen supplementation. And at that point, which was around day 11 of day 11 since onset of symptoms, the clinical team reached out to Gilead Sciences, which is the company that manufactures remdesivir, and requested for the drug through a compassionate access pathway. And they got the drug. And when treatment was provided, there was a significant improvement. And a few days later, the patient was discharged. And then later on, there was an overwhelming demand for remdesivir through the compassionate access route. And there was another publication in April where a group, again in the US, reported their findings from treating patients using remdesivir through this compassionate access program. And if you can look at the graphs on the right here, is that they demonstrated significant clinical improvement with remdesivir treatment. However, I would also exercise caution when interpreting this results, because this was purely observational. It was not in the context of a controlled trial, and there's a lot of limitation with the data. And if you look it up, there was a lot of criticism after this publication. Next slide, please. And to sort of, just after the publication of the compassionate access results in the US, there was another trial result that was published from China. In this study, they recruited 237 patients who had COVID-19, and really remdesivir was not found to be any better than placebo. But then the study was halted early because they were not able to recruit enough patients. And this was the time when COVID-19 pandemic was sort of, the outbreak in China was sort of leveling off, and the team acknowledged that they were not able to recruit enough patients. So the study was underpowered to provide any conclusions as to whether remdesivir does work or it doesn't work. And what followed next was the publications of the ACT-1 trial. Next slide, please, Sonak. And this was the adaptive COVID-19 control trial. It was an NIH-sponsored study conducted in multiple countries including United States, countries in Europe, and countries in South Asia. Unfortunately, there were no patients recruited from Africa. However, approximately 20% of the patients that were recruited into this study were of African descent. What was found was that remdesivir did confer significant clinical improvement, and the primary outcome here was time to clinical recovery. But then if we look at the next slide here, next slide please, Sonak, you'll realize that the benefit was sort of confined to patients who are receiving oxygen. So really patients who have severe disease and receiving oxygen, but not severe enough to the point that they require non-invasive ventilation or ECMO. And what we can get from this is that it's probably worthwhile initiating remdesivir treatment in patients earlier on, but then again, not too early, because patients who did not require oxygen also did not have any significant benefit from remdesivir. But then the authors also highlight in the paper that the difference between the B panel and the C panel here might be because of the numbers. Most of the patients who received remdesivir were actually severely ill and patients who required oxygen therapy. Next slide, please. And this really highlights the recommendations that have been put forward by the NIH, where first of all, remdesivir is regarded as an investigational antiviral agent for treatment of COVID-19 in hospitalized patients. And it's really confined to patients who have severe disease. And the definition of severe here is patients requiring supplemental oxygen therapy. And recently FDA issued an approval, an emergency use authorization, not an approval, an emergency use authorization for the drug. And that's why it's confined still to only investigational contexts, and it cannot be used in routine clinical care. And remdesivir is actually also one of the drugs that is being included in the WHO funded Solidarity trial. So we can see there is hope that we might be able to access this drug through the auspices of this Solidarity trial once it gets rolled out in our respective countries. We expect it to be rolled out in Kenya anytime soon. And Gilead Sciences has also sort of promised to be able to scale up production of the drug to the point of producing around 140,000 vials by the end of this month, and the hope is to produce around 1 million doses by the end of the year. And I would just like to highlight the panel does not recommend remdesivir treatment for mild or moderate COVID-19 disease outside the setting of a clinical trial. And I think I discussed this, and this is really based on the data that was published from the Act 1 trial. Next slide, please. And then there's also a recent publication. Now we have there's a shortage of supply of remdesivir, obviously, given the scale of the pandemic. And there's a significant demand of the drug, being the first drug to show efficacy to work against SARS coronavirus 2. So the question is, should we treat patients for 10 days, or can we achieve a similar level of efficacy by treating patients for 5 days? And this is a very recent publication, actually hot off the press, that was just published yesterday, that shows that there's really no difference in giving patients a 5-day course versus a 10-day course for severe COVID-19 disease. And most likely this is the pathway that most centers might be pursuing. But I'd probably suggest we keep an eye out and see if more data will be coming forth. There was a trend towards increased severity and with the 5-day course, but that was not statistically significant, as is clearly highlighted in this table that I've put up here. Next slide, please. And yeah, back to you, Sonak. I think that wraps it up for remdesivir. Thank you.
One of the complications that we're seeing with coronavirus is that there's an increased risk for thrombosis. This is data from one small study that was published just about a couple weeks ago, and you can see that there's an increased risk of venous and arterial thrombotic events for people in the ICU. So thrombosis is being seen as one of the things that's leading to increased mortality for these populations. I just want to very briefly share the guidance from the NIH and the American College of Cardiology, because they give conflicting guidance on this. The NIH says that there's not enough data yet to recommend that you should do prophylactic VTE treatments, so don't get prophylaxis, whereas the American College of Cardiology suggests that it might make sense to do it for people without risk for bleeding. And most people are recommending low molecular weight heparin, like enoxaparin, just because it has a lower, you don't have to interact with the patient as much. You can do it once a day rather than 3 times a day like you might with heparin. And there's greater data to support the prophylactic use of enoxaparin. As I said before, I wanted to share all the links that have frequently updated information. These are all the international ones, the NIH, WHO, and CDC. And then you also, on that first slide, have the link to the Nigerian CDC guidelines, which I assume will be changing as more data comes in. I now very quickly wanted to shift to vitamins and minerals, because there's a lot of questions about that. And this was another thing that was sparked in America by statements from President Trump about certain vitamins and minerals like zinc. I just wanted to share the rationale for these, but I want to say very, very clearly, there is no clear evidence that suggests that we should do this across the board. It makes a lot of sense, it makes rational sense, but we just have not seen any clear-cut data that suggests that we should give vitamins to everybody in the public. We should give it to healthcare workers. We simply don't have that data. You can see all of the reasons for promoting some of these vitamins. So, you know, vitamin D can reduce acute respiratory tract infections, potentially. Vitamin C can help your immune system, potentially. Zinc can impact immunity. All of these things that we know from other viruses that have rationale. We just haven't seen clear-cut data to say that it will work for coronavirus or even when you look at data looking at daily vitamin supplements, you know, the adult vitamins that a lot of people take, there is not clear-cut data that suggests that is necessary or that works. I myself typically take a vitamin, but I don't have great data to support this. So I'm giving you context for some of these responses. And I just want to share another bit of data on what some of the support for zinc is based on. So this first study over here is based on in vitro data looking at how zinc can bind to coronavirus and potentially impact it somehow. And so this was a study in 2010 on another coronavirus and it showed that zinc could potentially bind coronavirus. This, once again, was in vitro, though. We don't have human data to suggest that it could actually work on coronavirus. And I will say that there are ongoing trials, one big one in Melbourne that's looking at zinc infusions to actually address this. And then, I wanted to share what people are using as rationale for zinc as well. This is looking at zinc for colds and reducing the duration of a cold. So this Cochrane review that you see over here to the right found that there might be some small benefit with using zinc for colds, but still not compelling enough to recommend this for everybody. So you can see here, if you're to the left of this line, it shows that it favors zinc, and this shows that there might be a small reduction in the number of days of a common cold. Once again, this is what you use to support the logic behind using zinc. I am not recommending it because there's not enough evidence to suggest this for other people. Anybody can do what they want for their own personal health, but I do not feel there's enough evidence to make a definitive recommendation for zinc for other populations. Now, what I do want to say, though, that I think there is compelling information for is that there is no real shortcuts. I know as healthcare providers, I'm a pharmacist, we typically think of medications being the easiest way to basically address something. It's simple. I write a script, and all of a sudden, a patient gets this medication, and all their problems are solved. But that's too simplistic. What we've actually seen from larger studies is that changing the overall diet of people is what has a big impact. So my advice to you would not be to take more vitamins and minerals and supplements in tablet form. My advice would be to take more plant-based foods in food form. And we've seen that when people do that, that tends to have the health improving benefits. So this is not related to coronaviruses. This is general data from another study that was published in the Journal of the American Heart Association, which showed that you can basically reduce the risk of all of these things. So 16% reduced risk of developing cardiovascular disease. You can see the risk reduction for dying from health-related causes, and basically has pretty large effects on all of these things when you take a more plant-based diet as opposed to a meat-based and saturated fat-based diet from non-plant-based sources of diet. So my advice to you and my advice to the public would be eat more plants and vegetables and fruits and get the vitamins that way, because we do have fairly definitive evidence that shows that that works on reducing disease burden. And there's also data that shows that it improves your immunity as well. So that would be my guidance when it comes to vitamins and minerals. This just shows some of the benefits of a plant-based diet. I don't feel like going into details in that, but this is where we should really look to advise the public, is having a plant-based diet will improve many, many different aspects of health as opposed to just taking a tablet, which we don't have clear-cut data for. I'll very briefly cover vaccines. I just wanted to share the headlines of what people have released on this. And the reason I did this is because this one company, Moderna, has not given anything but this headline. And so there is some excitement about vaccines in that they are showing that they can generate an immune response and generate antibodies, but there's not enough phase 3 trials to document their use yet. But there is excitement, there is progress. I'm just sharing you what they shared because I can't evaluate any of their data because they've not released any of their data. This is essentially the extent of what they've shared, and what a lot of the excitement over the Moderna vaccine was, is just this basic statement that showed that they were able to trigger an antibody response in the participants that did the initial phase 2 trials for this. And then there was another one from a Chinese group that looked at an adenovirus vaccine. And once again, I don't want to go into the details of this, but basically they were able to trigger an immune response after giving a vaccine. So what I would say is that there is promising data and promising evidence on vaccines. The rapidity of the development of vaccines is unprecedented. We're seeing vaccines come up very quickly in a fashion that we've never seen before. So there is some excitement, and I think people can take some solace in the fact that hopefully there will be a vaccine available for the public within 12 to 18 months. And so that's something to take some hope in. But I wanted to just stop there for a second and cover the key takeaway messages from the presentation. And then once I do that and finish the last 2 slides, I'll start answering the chat questions. But you can see all these things. Select populations have additional risk for this. Treatments are emerging. Remdesivir has shown positive early findings. However, it is not a cure, and it's only shown moderate improvement. I don't want people to leave thinking that Remdesivir is this panacea and cure for all people with coronavirus, because it simply isn't. HCQ is not effective in the large registry trials we've seen, and it may be harmful. So I would not recommend hydroxychloroquine, which is HCQ, with the data we have. What vaccines are rapidly developing, and then the last points are that we need to follow the evidence, not the gut instincts of politicians with agendas. There's an article we wrote in the conversation that talks about this, and I think all of us as clinicians who are interacting with lots of patients have a responsibility to educate the population with data and evidence-based information rather than gut instincts. One last thing that I just wanted to touch on is we know from the HIV era that there will be major issues with access to medications and the distribution of this. So I want to start planting the idea about the ethical considerations. This chart over here shows you access to HIV medications for maternal to child transmission as of 2013. And you can see that there are still gaps, even in Nigeria, where there's people who don't get medications for when they're trying to prevent transmission to their unborn infants. So this is something we need to address. And the reason I mention this is because as we develop new treatments, there will be large ethical quandaries where we're not sure who's going to get the medication first. And as we get into more of an isolated world where we look after prioritizing our own interests first and putting everything else second, one of my big concerns is that there will not be an equitable distribution of vaccines or treatments around the world. So I just want people to be aware of that and start thinking about that and start advocating for equitable distribution of potentially life-saving products based on the needs of patients rather than government priorities. And lastly, this will be my last slide. I wanted to finish with a video, and then we can do the test and Q&A.
We hit the body with a tremendous...
If I could just pause for a second, I wanted to share, this reinforces my last point about not listening to politicians. So this was a video done by a comedian based on a statement that Trump made to the public during one of his press conferences.
Whether it's ultraviolet or just very powerful light. And I think you said that hasn't been checked, but you're going to test it. And then I said, supposing you brought the light inside the body, which you can do either through the skin or in some other way. And I think you said you're going to test that too. Sounds interesting.
If the right folks who could.
Right, and then I see the disinfectant where it knocks it out in a minute, 1 minute. And is there a way we can do something like that by injection inside or almost a cleaning? Because you see it gets on the lungs and it does a tremendous number of the lungs. So it'd be interesting to check that. So that you're going to have to use medical doctors with. But it sounds interesting to me.
And so my reason for wanting to show that video is because there's a lot of politicians who are making medical decisions for the public that are not based on the evidence. And it's important that the providers on this call actually have some, are able to correct the misinformation that's happening from politicians. And over to the right, this is another quick little clip of a New England Journal article written by some famous actors who basically say this idea that you can use bleach or ultraviolet light is basically ridiculous. And so my main message here at the end is that misinformation is rampant and all of us have a responsibility to correct it from our patients. I can tell you in America that after Trump made this statement, there was a dramatic increase in the number of calls going to the poison center because people were trying to drink bleach. As ridiculous as that might sound, people were actually listening to the president and drinking bleach to try to prevent them from getting coronavirus. So these kinds of comments have consequences. And I think it's important to follow the evidence and not follow the gut instincts of politicians who don't really understand the medical evidence and make suggestions They're not based on facts and based on instincts only. But with that, I think we can transition over to the post-test or the Q&A.
Okay, so thank you very much, Professor Sonak and Dr. Jamil, for the presentation. We have a lot of questions in the chat box. And just to jump on what you said last, it is not the trend of politicians giving advice on prevention and management of COVID-19 is not, specific, is not singular to the US as well. We have governors, we have politicians in here saying something like, once you wear a face mask, you're good. Corona can never get to you. So it is something that we as health workers need to keep correcting. And so we have a lot, and we anticipated this. We have a lot of questions around the use of hydroxychloroquine and even chloroquine. And I'm just going to bunch them, into a summary. In a nutshell, use or don't use hydroxychloroquine or chloroquine.
My advice at this point is I would not recommend it for the public based on the evidence we have. And there are risks. So when you use it at the scale that we're talking about, there will definitely be a portion of the population that observes these risks and has these risks. And we don't know how many people will actually benefit. So my recommendation with what we know now is no. And most guidelines have removed hydroxychloroquine as a treatment option.
Okay, so a follow-up question to that is, how did this high dose of hydroxychloroquine even come about? And are the poor results or that we're getting from it due to the high dose? Could we use a smaller dose and achieve results? And can this, sorry, I'm laying out, and if yes, is there a prophylactic dose that can be used, especially for like healthcare workers who are right at the front lines?
There's simply no data to suggest that there is an efficacious option to do that. There's ongoing studies. If you look at the NIH document, there's about 5 or 6 ongoing studies for hydroxychloroquine, but the data is not out yet. So there is no recommendation to do that that I could support.
Okay, so for now, the answer is no, and for even a reduced dose.
And once again, this is going on my opinion. This is my opinion based on my evaluation of the data. Yes, that is what I would say. I would not recommend hydroxychloroquine.
Okay, and so are the side effects higher for hydroxychloroquine than for chloroquine? In terms of the ventricular arrhythmias, is it higher for any of them, or is the same effects?
Let me just show you. So we don't know definitively, but if you look at this slide, this is the registry looking at the risk of ventricular arrhythmias, which are basically abnormal heart rhythms that affect the ventricles. Basically, you can see that chloroquine had a higher risk of ventricular arrhythmias. And part of the reason why we've stopped using chloroquine so much is because it has a higher risk than hydroxychloroquine. So based on this study and based on past studies, we would basically prefer hydroxychloroquine over chloroquine because there potentially is less risk. Now, macrolides are thought to potentially increase that risk as well. So when you combine it with a macrolide, there is potential for more risk. But I'm going to let the data speak for itself because I don't think I can give you a definitive answer because these are all subgroup analyses of a much larger cohort. I'm just telling you how I would interpret this if you forced me to answer that question, but we don't have a definitive study that clearly defines that.
Okay, and one of the hospitals was asking if Nigeria was part of the multinational registry analysis that you mentioned, if Nigerian statistics was included.
Yeah, they didn't mention the exact hospitals in the appendix, But the thing they just showed was the number of hospitals per continent. They didn't show me countries. So I don't know definitively the answer. My guess would be yes, though, because most large-scale studies that include African hospitals usually include at least one from Nigeria because of the advanced infrastructure you have to do trials there. So my assumption would be yes, but I don't know. They didn't tell me the exact names of the hospital.
And one of, given the wide range and different cadres of healthcare workers and just also some partners, some non-medical listeners who are not core healthcare professionals on the call, if you could just remind everybody what ventricular arrhythmias are and why it's so dangerous.
Yeah, so just to give a very simple explanation, it's basically an abnormal rhythm of your heart. So, you know, you have a pretty standard way that your heart beats and all the conduction that happens. What happens with some of these medications is they alter those rhythms, and these medications can sometimes cause a change in the rhythm that basically impacts the way that signals are transferred to your ventricle, which helps your heart contract. So basically there's an abnormal signal pathway that happens, and the way that you get a heartbeat is not normal in the presence of some of these medications when they cause this side effect. But once again, I just want to emphasize that it is a fairly rare side effect. So do not think that anybody who takes it is going to get it. That would be very, very far from the truth. It is very, very rare. But when you do it with a large enough pool of people who might have underlying conditions, there will certainly be people that have this side effect.
Okay, and then we have a question from Dr. Charity regarding hydroxychloroquine therapy, and it says, I suppose the risk of ventricular arrhythmias will be more in patients with cardiovascular disease than in patients who are taking a lower dose for prophylaxis, who have no cardiovascular challenge.
Correct. So if you already have heart conduction abnormalities, those are the populations that these medications typically affect. And we know that there's a lot of populations that have these underlying cardiovascular diseases that aren't diagnosed. And so when you start using a medication like this at scale without doing the follow-up and evaluation, you're bound to give it to somebody who has increased risk.
Okay, so chloroquine was a very popular drug in management of malaria in the past. Was ventricular arrhythmias, a concerning side effect back then as well, or is this new knowledge, or is this dose related?
No, it's known. It's been known for a while, but I want to emphasize again that the risk is fairly minimal. When you compare the risk versus benefit of malaria versus this very small risk of a ventricular arrhythmia, there's no comparison. The risks outweigh the benefits outweigh the risk in the context of malaria. Whereas for coronavirus, when we don't have definitive efficacy, in my opinion, the risks do not outweigh the benefits. But for malaria, it does. It still is a very low risk.
Okay, so we have two questions that are very similar. I'm going to combine it from Datonye and from Daisy. And it's saying, okay, if we're saying this, right, the antiretrovirals are not a cure. Hydroxychloroquine is not working. For those who have recovered so far, was it trial and error? And to add on that, is then a vaccine really necessary if it seems that it is the immunity pre-COVID that seems to be determining or the coexisting conditions, or characteristics of the person that seems to be determining whether the person survives or not?
Yeah, there's a lot to unpack there. I'll pick out the points that I think are worthwhile. I think what coronavirus does is the wake-up call to all of us to improve our general health. And that's why I included the slides on improving our diet, reducing things that we know definitively are harmful, reducing smoking. We know that smoking is harmful. Those are all things that increase the risk of coronavirus. So the best preventative things that I would actually recommend are things that improve our general health, because it increases your disposition if you were to be unfortunately infected with coronavirus. Now, it's worth noting, let me just go back a couple slides. So if you look at the US, there's about 1.6 million confirmed cases. We only have 100,000 deaths though. So I want people to think about these things in context. Clearly 100,000 deaths is a lot, but I don't want people to run around with this notion that if you get coronavirus, you're gonna die. It's a fairly low fatality rate, and that fatality rate is modulated by all of these other factors like age, underlying diseases. And so my advice to people is to get their health in order and prevent some of these other modulating diseases like diabetes, cardiovascular disease, smoking and pulmonary disease. All of those things are very good preventative strategies to reduce your risk of having death from coronavirus. And then to unpack the question a little bit more, Remdesivir was statistically significantly helpful, but I don't want people to think it's a cure because it will help some people and it might not help some people. So it's not a clear cut like, okay, you've got this silver bullet all of a sudden. If you have coronavirus, get Remdesivir and you're good. It's not that. And I just want to be clear so that we understand the data in context, that it does help some people, but it doesn't help everybody. The main thing to do is to prevent transmission at all. And if you can control and improve your health overall, that's what you should do. And hopefully a vaccine will be the thing that allows us to get more immunity in the population and reduce transmission and limit the burden of this disease.
Okay. So the next question is, knowing the data is inconclusive, if you had a good friend working in a hospital as a nurse or a physician exposed to COVID-19 with new onset of questionable symptoms such as terrible headaches, GI symptoms, dry cough, low-grade fever, what would you say they should take? Recognizing the reality of self-medication in health workers.
Yeah, so the other thing to note with coronavirus is that there's a mild to, there's a large portion of people who are completely asymptomatic. There's a mild to moderate progression, and then there's more severe. So, I think keep that into context, and you tried to give some details on that. But if they were severe, then I would definitely make sure that I tried to get them Remdesivir and make sure that I had ventilation capacity available. Even if it was mild to moderate, despite the fact that there's not great support from the guidelines on this, you might consider something like Remdesivir, but I wouldn't be too insistent on it. What I would want to know is whether they were elderly, whether their risk of progressing was higher than the general population. And if it wasn't, then my guess is that probabilities would suggest that they will be just fine if they get supportive care and do all the things that they're supposed to do in terms of, adequately hydrating, taking vitamins, and eating a healthy diet, and getting the vitamins from their diet. I don't know that there's a specific treatment that I would pin all my hopes on. My hope would just be to have Remdesivir available if it was possible. And there's other adjunctive therapies that are being considered, but it would basically be supportive care and make sure that they had access to things if their case got worse. Jamil, I don't know if you have additional thoughts on that, but let me not monopolize the questions.
Yeah, no, I totally agree. The mainstay of therapy for patients with COVID-19 is largely supportive, and a good number of patients can actually be managed from home. All they need to take is probably an anti-inflammatory drug. And probably we need to look at COVID-19 from a wholesome perspective. In one aspect, there's the viral replication, which we are trying to target with all these antivirals, but this is also the inflammation that is associated with the disease and the immunomodulation that is associated with the disease. And most of those are just treated with standard supportive care. So like paracetamol if you're at home and other anti-inflammatory agents. But just one point to note there is that there was a bit of caution in terms of using some anti-inflammatory drugs such as the NSAIDs, because there was that theoretical risk that it might increase the risk of getting liver failure, something like a Rye syndrome. But like what you said, Sonak, only less than 10% of these patients will land into hospitals. And among this, another less than only half of these patients will land into the ICU. And that's where it gets a bit tricky. We really need to identify who are the progressors that might go into severe disease versus those who might not progress into severe disease. And those are the patients that we would want to include into a clinical trial. And I would want to emphasize that most of these drugs are still investigational, and they can only be administered through the context of a clinical trial.
Okay. We're wrapping up the questions, looking at the time. Ipaja, PhD, and I'll ask this to you, Dr. Jamil, is saying, has there been any record or evidence of maternal to child transmission of COVID-19?
Yes, there are a few reports that have been reported of vertical transmission of COVID-19. And there's also, I think, a case report of neonatal mortality from COVID-19. So death of a newborn child from COVID-19. However, it's very limited data. And I don't know what your thoughts are, Sonak. My belief is that the verdict is still out on this.
That's what I would say. It's not clear yet. And you know, the initial papers that came out were more positive in suggesting that it didn't seem like pregnancy had much relationship or consequence related to coronavirus. But the data is still fairly limited, and the verdict is still not clear.